Hello and welcome back to BunMed, where we discuss concise medical knowledge that you can fit inside of a bun. In today's video, we are going to be having a look at the mechanisms of hyponatremia, and specifically how they may occur and how we may approach a patient with hyponatremia. So let's start by defining what hyponatremia is. Hypo refers to low, nat refers to sodium, and emia refers to in the blood. So therefore, in hyponatremia, we have low amounts of sodium in the blood. And in the lab, we discuss this as a concentration of sodium of less than 135 millimoles per liter. Now, when we have someone with hyponatremia, what we have to question is, do they have true hyponatremia, or do they have a false or pseudo hyponatremia? So how do we go about doing this? Well, in order to work out if they have true or pseudo hyponatremia, we must first calculate how concentrated or how dilute their blood is. And we can do this by using an equation known as that which calculates the serum osmolality. And that is 2 lots of the concentration of sodium plus urea plus glucose. And this will give us an indication as to how concentrated or dilute the patient's blood is. If we find that the patient's blood is actually quite dilute, or that of less than 280 milliosmoles per kilogram, we can say that they have a true hyponatremia. However, if we find that their serum osmolality is somewhere between 280 to 290, what we can say is that they have a pseudo or a false hyponatremia. And this may occur in cases where they have excessive amounts of fats in their blood, such as that of hyperlipidemia, or that of hyperproteinemia, where they have excessive amounts of protein in their blood. So now that we've established that this patient may have true hyponatremia, what are some features of hyponatremia? Features of hyponatremia may vary from mild to moderate to severe. Mild to moderate features of hyponatremia usually occur over a period of 28 hours, as in they last longer than a period of 48 hours. Features of mild to moderate hyponatremia, or those lasting longer than 48 hours, may include things like lethargy and fatigue, confusion, altered mental status, as well as a bit of dementia, and a patient not being able to remember things or being more forgetful. As well as this, they may experience things like muscle cramps as well. However, hyponatremia may indeed be severe, where features present in less than 48 hours and present very acutely. This occurs when the concentration of sodium in the plasma falls so low that surrounding tissues, especially that of the brain, become much more concentrated than that of plasma. This causes water to start to move into our brain, causing the brain to swell up and leading to cerebral edema. As the brain starts to swell up, we get a raised intracranial pressure, and our intracranial pressures start to go up, which may present as nausea and vomiting. However, as the brain continues to expand, it has nowhere to go, so therefore it may start to herniate through the foramen magnum, the opening at the base of our skull. This may lead to things like coma, or if the herniating brain presses on the brainstem, may actually lead to death as well. So this is a very, very serious condition. And as such, those with severe hyponatremia need to have their serum sodium levels corrected quickly with the use of hypertonic saline, specifically 3% sodium chloride saline, just to ensure that this doesn't happen. Now that we understand how severe hyponatremia can be, we must understand why hyponatremia may arise. So in this, we have a very simplistic diagram to explain how hyponatremia may occur. Here we can see we have a beaker of fluid, and into it we have dissolved our sodium particles. And this gives us the concentration of sodium. And this is exactly the same as how sodium exists in our blood, dissolved inside of plasma. To alter this concentration of sodium, we may add water, or we may remove sodium. Both actions will lead to a decrease in serum sodium. So now that we understand that adding water or taking water away or taking sodium away affects the concentration of sodium in our blood, we can actually apply this in assessing patients with hyponatremia. As such, just like the diagram, we can split patients up into 3 different groups. Those who have hypervolemic hyponatremia, where they have excessive amounts of fluid and low sodium. Those who have euvolemic hyponatremia, or those who have a normal amount of fluid, however they're still low on their sodium. And those with hypovolemic hyponatremia, patients who are fluid depleted and have a low sodium. So let's focus on patients with hypervolemic hyponatremia first. In these patients, the patients often have too much fluid and are fluid overloaded. Features of this may include things like a raised jugular venous pressure, or JVP. The excessive fluid may leak into our alveolar spaces, leading to shortness of breath due to pulmonary edema, or the fluid may accumulate in the pleural spaces, leading to pleural effusions. The fluid may also exist in the vascular system, leading to hypertension or raised blood pressure, or may actually escape into our peritoneal cavity in the abdomen, giving us abdominal distension due to ascites. The fluid may also escape into our limbs, giving us peripheral pitting edema. Now, why might the patient be fluid overloaded? Well, they may have a pump failure, where they're not able to pump the excessive fluid around their body, in the cases of heart failure. They may have a broken filter to remove excessive fluid, such as that in renal failure. Or they may not be producing enough protein to be able to hold on to that water in our vessels, such as that of liver failure. Now, what about hypovolemic hyponatremia? Well, in these cases, patients are often fluid depleted due to excessive loss of water and sodium. Features of this may include sunken eyes, dry mucous membranes, tachycardia, and if our heart cannot compensate by pumping faster, we may get hypotension. And as well as this, patients may get a reduced skin turgor. Things that may cause this include things like diuretic use, or the use of drugs which stop sodium and water reabsorption in the kidneys, diarrhea and vomiting, as well as severe burns. In euvolemic hyponatremia, we have a completely normal fluid state, so our clinical examination is normal. And this usually occurs due to a dysfunction of fine-tuning of serum sodium. And this may occur in conditions such as SIADH or psychogenic polydipsia. Now, a classic exam topic is to try to differentiate between SIADH and psychogenic polydipsia. So how do we go about doing that? Well, in order to do this, we have to understand how SIADH works. So what is SIADH? Well, SIADH is a syndrome of inappropriate ADH secretion. So what does ADH actually do? Well, in the collecting tubules, this is the very last part of our nephrons in the kidney, our ADH works on this specific receptor known as V2 receptors and causes the expression of aquaporin channels. These are very specialized channels which can go across the cells of the collecting duct to the renal tubule and shuttle over water molecules inside of our blood, thereby concentrating our urine and making our blood dilute. In the case of SIADH, we have excessive amounts of ADH present, and therefore we get even more aquaporin channels, which can reabsorb even more water, making our blood extremely dilute and our urine extremely concentrated. In the case of psychogenic polydipsia, however, we have an increase in water uptake. This leads to a reduced serum osmolality as our serum becomes quite dilute. This is detected by our kidneys, which gets rid of all of that extra water inside of our urine. So we actually end up making very, very dilute urine. And here comes the differentiating factor. In SIADH, due to excessive ADH, we have extremely concentrated urine. So our urine osmolarities are high. In psychogenic polydipsia, we have very, very dilute urine due to very, very dilute blood, and therefore our urine osmolarities are low. That concludes the video. Hope you guys found it useful. Please feel free to share and subscribe. And if you have any comments, leave them below and we'll get back to you as soon as possible. See you in the next one.